Good morning. I'm Dr. Duke Majan. We're going to be live streaming spine surgery from Duke Spine Institute here in Florida. It is November 11th, 2025. Our patient is Veterans Day, so happy Veterans Day to all of our vets. Thank you for your service. We've treated many veterans of war here at Duke Spine Institute. We have Patrick's Air Force Base close by, and my father is a veteran of the United States Army, served in Vietnam. All right. Our patient travels from Iraq for his surgery. He's a doctor. He's came with his wife, and he has 3 herniated discs, C6-7, C5-6, C4-5 in that order, 6-7 being the worst. He has arm symptoms on the left, and he's getting some symptoms in his leg as well. He has neck pain. He's had it for 8 years. He went elsewhere for treatment first. He had a disc FX procedure, which did not work. It's where they stick a needle in your neck and try to suck out some of the disc, hoping that it'll suck the herniation back in. I don't believe in that procedure. It doesn't work. I'm aware of it. I don't use it because it doesn't work. How relaxed are we? All right, so we're going to give our patient is asleep. We're going to give him some more anesthetic, some more muscle relaxer, actually. And his face is up here looking at you. He's intubated, asleep on general anesthesia. He's on a ventilator. This is the front of the neck. This is the right side of the front of the neck. We're going to be going in and repairing 3 discs with the endoscope and laser. We call this the Duke Laser Disc Repair. We've produced this or performed this procedure for 20 years here at Duke Spine Institute, 20 years. We've done over 2,700 endoscopic laser surgeries. While we're waiting for the muscle relaxer to take effect, if you have questions during the surgery, feel free to type up your questions. We are live streaming on LinkedIn and, actually X, Facebook, YouTube. I don't know if we're still streaming on LinkedIn. I don't know if we are. We used to, but LinkedIn doesn't like our live streams for some reason. Huh? All right, yeah, it feels good. So his neck is supple. I'm going to place my needle. That's the first step. All right. I want to see where we are. Shot. 2, 3, 4, 5, 6, 7. So we're at 5-6. I'm going to go ahead and start with 5-6. All right, shot. So 2, 3, 4, 5, 6. I need to be just a tiny bit higher. Shot. All right, let's get an AP. If you have questions, feel free to type them up. 2, 3, 4, 5, 6. The needle is at 5-6. It's perfect. You can see I've displaced the trachea and esophagus way over. That's it right there? Yes, all right. So I can't see here. I need to see down in here.
I need to move that one, please.
All right. That looks good. Shot? That looks good. All right. Shot. AP. Shot. That looks good. Lateral. We're going to use AP and lateral x-rays to localize and navigate both. Localization means to get the right disc. Shot. Navigate means to get into the disc. Shot. AP. If you have questions, feel free to type them up. Again, this is a patient who traveled from Iraq all the way to Florida to have his surgery done. All right. Let's get that lateral done again. I think I want to come a little bit more towards me with that needle. Shot. Shot. Let's get an AP. I'm right in front of the spine. Alright, so it pushed me over. I have to start again. Shot. I like to get this part absolutely perfect. Shot. Why does it look like you have scoliosis with that neck? Can you straighten them up, please? Shot. 2, 3, 4, 5, 6. Shot. AP. That looks perfect right there. Shot. That looks good. That looks good. AP. So we're using the AP and lateral views to make sure we're exactly where I want to be as I enter the disc through the front of the spine. That's perfect. You can see the midline of the spine where the spinous process is. Now I'm going to push into the disc a little further. I want to get into about the middle of the disc. Remember, his symptoms are primarily on the left arm, left cervical brachial, left arm. So I want to come from the opposite side, the right side, when it comes to the neck. Shot. Oh yeah, look at that herniation. Look at the tear. Shot. It is huge. So you can see the giant tear. It's the dark stuff. It should not be leaking out the back of the disc. It should stay in the middle. Show us where the middle is. Yeah. Circle the cotton ball. That's where the dye should stay. Now look at the front of the disc. You see there's no tear. That's what it should look like. The dye should stay right where the nucleus is. But show us where the tear starts. The tear starts right where the arrow tip is, right there. And it extends all the way back. That's called an annular tear. And he has one at each of 3 discs. Now 2, 3, 4, 5, 6. I'm at the middle disc. We're going to go down to 6, 7 next. But we're going to fix 5, 6 first. So, any questions? Type them up. Henry, let's show the audience, since we're talking about neck pain, which this patient has, there are 30 things that cause neck pain. Let's show the audience the 30 different causes of neck pain. I'm Dr. Duke Majan, CEO and founder of the Duke Spine Institute. We're going to talk about the 30 causes of chronic neck pain. Chronic neck pain is neck pain that lasts longer than 6 weeks. There are 30 causes to chronic neck pain. The most common cause is the disc. There are 6 discs in the neck. These discs can become injured. The first disc is C2-3. Next is C3-4, C4-5, C5-6, C6-7, and C7-T1. The most common disc to be injured and cause neck pain is C5-6, followed by C6-7, followed by C4-5. The other discs rarely cause pain. Discogenic pain represents 85% of chronic neck pain. Next, the facet joints cause 10% of chronic neck pain. Facet joint pain is very common in patients with neck injuries and spine injuries. Facet joint pain is usually located on the sides of the spine, either right, left, or both. Facet joint pain gets worse with rotation of your head and neck, worse with extension. The most common facet joints to be injured are C5-6, C6-7, and C4-5. C7-T1 is another common facet joint to be injured. These joints, after injury to the capsule, will develop arthritis. It is the arthritis in and around the facet joint that causes the neck pain and stiffness with movement. Duke plasma rhizotomy is the best treatment in the world available for painful facet joints. Duke laser disc repair is the best treatment in the world available for painful discs. Other causes of chronic neck pain include fractures, tumors, infections, and muscle spasms. These other causes represent less than 1% of chronic neck pain. Thank you for joining us for 30 causes of chronic neck pain. Take a look at this x-ray. You can see where the white arrow is pointing to the tear on the right side and the tear on the left side. And that tear has dye in it. That's why we're able to see the tear. It's called a discogram. And you can see the dye is leaking out around the nerve roots. That's the nerve root right there, right where it hooks on both sides. So this tear is causing inflammation. It's affecting neck pain and arm symptoms. Lateral shot. All right, so here we are going to the back of this disc. This is a large herniation. It's a lot worse than it was on the MRI scan when I originally saw it. You can see the herniation. Show the herniation. You guys see the dye right there? That is the herniation. The dye is getting around the herniation. Shot? All right, the tip of the dilator is exactly in the back of the disc, right where the tear is. We're going to do the entire surgery through this tube, folks, right here. Okay? This tube is 4 millimeters. 4 millimeters. That's it. Tiny. So I'm going to place the tube over the dilator. Shot. You can see that the disc has pushed the dilator back right there. I had it further back, but it pushed the dilator back. That's the pressure inside the disc from inflammation. Shot. All right. Shot. Almost there. I don't want that dilator moving back any further than it is. I'm in the front of the disc now with the tube. I made the surgical incision on his neck is 4 millimeters. Now, if this patient had, remember, he's from Iraq, he's a doctor, so he could go pretty much where he wants for treatment, thank God. And he chose to come to Duke Spine. That's why he flew here with his wife, and he's flying back to Iraq afterwards. But he also originally had another procedure called the disc effects. I told you guys briefly about it. It doesn't work. That's why I don't do it. I only do procedures at Duke Spine that work, that cure pain permanently. We don't need to do procedures that don't cure people's pain. So we do procedures that cure pain. And this patient, he had the disc effects done, and it didn't work. And he was looking at his options. He went to Turkey, and they recommended fusion, 3-level fusion. He did not want a 3-level fusion. He's a doctor, he's young, he's active. He did not want fusion. He knew that fusion has high complication rate. Shot? So he chose to come to the United States to have Duke laser disc repair. And I will say, he's our very first patient that comes from the Middle East. We've had Israelis, but he's the first Iraqi patient. I believe he's obviously Arabic, and we're going to have more. We have another patient in 2 weeks coming as well. So we are finally reaching the Arab nations, and people are coming because they realize this surgery is better than anything available to them elsewhere. Any questions?
Yes, we have a question coming from Lanu on YouTube.
Hello, Lanu. Welcome.
A question for me asking if I wear glasses and looking at monitors for hours can be hard. Yeah, I don't necessarily wear like everyday glasses, but sometimes I wear UV glasses to help with my eyes to look at monitors for so long.
All right, thank you, Lanu. Let's turn the light intensity down 1 click or 2 clicks. Luis, are you doing the right thing? It doesn't look like it went down too much. Folks, here's the herniation right there. That's part of the herniation. This patient has 3 discs that are herniated, C4-5, C5-C6, C6-C7. We are first treating number 5-6. It is not the worst one. 6-7 is the worst one. But you can see the herniation right here.
Yes, we do.
Just for reference, that laser fiber at 12 o'clock on your video, that fiber is 0.5 millimeter, 0.5 millimeter wide. So that gives you a perspective of what the magnification is going on here. So you guys are able to see. This is herniation right here that I'm removing with the laser. Now we have people who are offered surgeries elsewhere like Germany or in Arab countries, but the surgeries that are being offered are older surgeries that are dangerous, like fusions, artificial disc replacement. All of those surgeries are invasive, and they end up causing problems for the patient, okay? Whether it's complications from surgery or it's long-term problems related to the surgery, such as adjacent segment disease or pain, worsening pain, very common for people to have those disc replacement or artificial disc and they have worsening pain. All right, look here, this is very important. We are at the back of the disc. This is the annulus that's torn. It's got inflammation. You guys see that right there? That's a tear in the posterior longitudinal ligament. You can see the dura of the spinal cord down there, okay? Right down there. So we want to be very careful. We're going to stay away from that. We're going to remove this herniation right here, which is pushing on the spinal cord right there. So this was C5-6. When I talked to the doctor, I said you can just do number 6-7 if you want, because that's the worst one, but I think you should do 4-5 and 5-6 as well. You're coming all the way from Iraq. You should have everything done so you don't have to come back again. And he's young, and he wants to be active. He wants to do sports. He has a practice. I can't tell you what kind of doctor he is, but I'll just tell you that he's a doctor in Iraq, and he has a very busy practice, and he has not been able to practice properly because of this symptoms in his neck. We have a lot of doctors who come here with problems with their spine, like herniated disc, and they know that the invasive surgeries like fusions or laminectomy, disc replacement, ACDF, PCDF, all those invasive surgeries cause permanent damage to the spine. The surgery itself will damage your spine, and they don't want that. They know better because they see the patients that have those surgeries, and the patients may do okay for a little while, like a few years after those invasive surgeries, but eventually the patients are going to come back complaining of worsening pain because they develop adjacent segment disease or they get complications from invasive spine surgery. Henry, let's show the audience why the Duke laser disc repair cervical is better than these other treatments that people consider for disc herniations in their neck.
Of course.
I'm Dr. Ara Dugmejian, CEO and founder of the Duke Spine Institute. I'm here to talk to you today about neck pain and its common treatments. Neck pain has different causes. The most common cause of neck pain is a herniated disc. Herniated discs account for about 85% of chronic neck pain. The second most common cause of neck pain that's chronic is the facet joints. There are facet joints on both sides of the spine, left and right. There is one facet joint for every disc. Facet joint pain requires a different kind of treatment targeted at the facet joint itself. For disc pain, which accounts for 85% of neck pain, the best treatment in the world is the Duke laser disc repair. It is the most advanced treatment that is the safest and has the highest chance of successfully eliminating symptoms. Let's talk for a moment about what's important for patients who are considering treatment for neck pain coming from an injured or damaged disc in their spine. The most important thing for patients, number one, is getting rid of their symptoms. The type of symptoms that disc herniations or disc injuries can cause include neck pain, headaches, and symptoms down the arm, such as weakness, numbness, tingling, or even pain shooting from the neck down into the arm. The symptoms of neck pain include disc herniations, which are the most common cause, and patients want those symptoms gone. That is their number one priority and goal. The second most important goal for most patients is to avoid a complication from the treatment. Medical treatments do have complications, and the more invasive the treatment, the more likely a complication will occur. Complications from surgery, for example, can include blood clots, pneumonia, heart attack, infection, failure of the spine to heal properly after surgery. There can be implant migration or implant failure, adjacent segment disease, and vascular complications such as injury to the blood vessels or nerves in the neck, including the trachea and esophagus. Nobody wants a complication from spine surgery on their neck, so less invasive is typically going to be a better option to avoid those complications. The third thing patients really want when they're looking at treatment options for curing their neck pain is they want a quick recovery. People want to get back to a normal life as quickly as possible. They want to go back to their activities, they want to be active, they want to play sports, and they want to go back to work. And finally, the next thing to consider is long-term results. For example, if you have a treatment today and it works, how long will that treatment last, and will it create additional problems down the road for you? Treatments like spinal fusion that are invasive typically result in the need for additional treatments such as pain management, physical therapy, and possibly additional surgery. We're going to look at each of these individually and go through each of these options individually. So we're going to start with more invasive treatments that are typically recommended for patients with herniated discs or degenerated discs in their neck. The most common treatment recommended around the world is anterior cervical discectomy and fusion. That is a surgical treatment where the entire disc is removed surgically through a large incision that is very risky. There's bleeding associated and risk of injury to surrounding structures such as the esophagus, trachea, and blood vessels in your neck. Complications are very common with this type of surgery. The complication rate is accepted at 48%, which is a very high number. So if you're considering ACDF or anterior cervical decompression and fusion, you are looking at a very high complication rate. The success rate of this surgery at eliminating neck pain is very low. It's somewhere on the order of 25%. That is the generally accepted success rate at eliminating neck pain. An additional treatment that you can consider is artificial discs. Artificial discs are very similar to ACDF. The difference is instead of fusing two bones together with a metal plate and a cage, we're actually putting in a mobile disc made out of metal and plastic that moves. The problem with the movement is that these discs do pop out of the disc space. Over time, they can fail. They can cause collapse of the vertebral body above and below through fracturing, especially in patients with weak bones such as osteopenia or osteoporosis. Those types of patients are at high risk for complications from both ACDF and artificial discs. Another complication from artificial discs is that you can develop facet joint pain and adjacent segment disease, very common with artificial discs and fusion, and they typically have the same rate of adjacent segment disease. There's also a long recovery associated with both ACDF and artificial discs. Recovery can take months to years, if recovery even happens at all. There's tremendous scarring in the wound associated with ACDF and artificial discs, lots of scar tissue, lots of pain, and lots of problems after these surgeries that are invasive. Alternative treatment would be to go in the back of the neck and do a cervical laminectomy and fusion. Again, large incision, high chance of complications, very long recovery, taking years to recover. All three of these types of surgeries, ACDF, artificial discs, and posterior cervical laminectomy and fusion, require the use of postoperative narcotic painkillers. Narcotic painkillers are opioids. They are dangerous. People get addicted to them, they can be abused, and people can overdose. It's easy to overdose on narcotics because you want to keep taking them to treat the severe pain you're going to have after these invasive type surgeries. The severe pain can last weeks or even months, and the addiction can happen very quickly. Let's move into less invasive treatments such as epidural steroid injections. This is a treatment commonly recommended by pain management doctors. They stick a needle into your spine and inject the steroid medicine to reduce inflammation. While this treatment can be effective at temporarily giving you relief for a few days or even a few weeks, the pain always comes back from a herniated disc because the source of pain is never being treated. The annular tear and inflammation within the annular tear is not treated by an epidural steroid injection. The steroid goes throughout your body and causes systemic side effects such as high blood pressure, elevated blood sugar. In patients with diabetes, this could put your sugar up into the 300s and 400s, which is very dangerous for patients. So steroids should be avoided as much as possible. Next, let's turn to spinal cord stimulators. The problem with spinal cord stimulators is they are highly invasive and they are frequently put into patients by untrained doctors who are not surgeons. These doctors are typically pain management specialists, and they're putting these stimulators in patients not because they can cure your pain, but because it's another treatment that they have up their sleeves. These treatments with stimulators pay these doctors obscene amounts of money. The profit for the doctor can be in the tens of thousands of dollars. Avoid spinal cord stimulators. They do not work. They're dangerous. They put you at tremendous risk, and in the end, basically you're taking this device, sticking it on top of your spinal cord and putting a pacemaker under your skin that you're going to have to live with for the rest of your life. They cause scar tissue and they frequently migrate and get out of position. Next, we're going to talk about physical therapy. While physical therapy has many benefits, such as keeping you toned and fit while you're struggling through the pain and trying to stay mobile, but physical therapy will never, ever cure pain in the neck from a herniated disc. It will just try to keep you active and from getting more and more sedentary and developing deconditioning of your muscles because you're sitting around because you have neck pain all the time. Finally, let's talk about the Duke laser disc repair. The Duke laser disc repair is the solution for neck pain. If you have a herniated, bulging disc, extruded, ruptured disc, protruded disc, or degenerated disc, the Duke laser disc repair works by minimally invasive treatment going to the back of the disc where the problem is coming from. This is the tear in the back of the disc that has inflammation, and using a laser that is extremely precise. The laser fiber itself is 0.5 millimeter or half a millimeter wide, and the endoscope allows me to see 1/20th of a millimeter. I can directly see the nerves and spinal cord. It is an extremely safe treatment. As far as results go, the Duke laser disc repair has the highest success rate of all the treatments we've discussed so far. We have a 99% cure rate of neck pain coming from herniated discs, and the Duke laser disc repair has 0 surgical complications to date. Our patients have an immediate recovery. In 1 hour, they're leaving our facility and they're going back to their hotel room. They usually drive themselves in the next morning for a quick checkup, and then it's back to a normal life. Well, I've enjoyed talking to you, and thanks for taking the time to listen to our video. I'm Dr. Ara Duke-Majan. We'll also find this on our podcast at Duke Spine Institute Podcast. Thank you. Welcome back. You can see from our video actually that Henry produced that the Duke laser disc repair, the surgery you're watching right now, is the best in the world for treating any type of disc problem, whether it's herniated disc, degenerated disc, disc extrusion, disc protrusion in the neck, anything with the disc, which is 90% of the time that's what people have. And we are at the back of the disc, number 5-6. And wow, this is so bad. It's so much worse in here endoscopically than we could see on the MRI. The MRI did not show the true extent of damage. But this is the foramen on his left foramen, neural foramen, C5-6. And I've been removing so much herniation. Probably 30 pieces of herniation have come out. And the foramen is now clear. There's just a little bit left there. And you can see the posterior ligament right here, posterior longitudinal ligament, a lot of scar tissue because a lot of inflammation's been going on. His body has been trying to heal this for 8 years, but he's not been able to heal it. This is all scar tissue, the white stuff. Scar tissue within the posterior longitudinal ligament. Beyond the posterior longitudinal ligament is the spinal cord right there. So we have cleaned out all the herniation that was pinching on the nerves and spinal cord. And this is number 5-6. We're going to move on to number 6-7 next, okay? But this looks really good. I even got rid of some bone spurs. These are bone spurs here. Okay, there was a bone spur right there. You can see that bone spur. I got rid of it. That was in the foramen. I'm going to go look at the other side again just to make sure I got everything. But this is disc number 5-6. This was the second worst disc. The worst disc is 6-7. All the herniation is gone. You could see foramen to foramen. This is a piece of herniation. This is probably the last piece. That's why I always go back and double check, because you never know. There's always going to be another piece of herniation that may present itself while you're working on the other side. So I'm floating it out of the tube. There it goes. There's another piece. So many pieces of herniation. It's unbelievable. I'm going to try to grab that one out. Any questions?
We have a comment and a question. This comment is coming from Lanu once more on YouTube.
Hi, Lanu.
Saying the bones on this patient seems to be a little thick, just my opinion. He has a huge tear. Might be an old injury?
Yeah, the tear is we know it's probably around 8 years old based on his symptom start. and everything I'm seeing supports that. But at the same time, the disc is well preserved. So once we clean out this herniations, what we should be left with is a good disc, a functioning disc that is going to heal itself and get better. I think this is the last bit. You can see it's mostly scar tissue. The gold color is dystrophic calcification. This is the foramen right here. I've gotten rid of the herniation that was in the foramen. There's just a little bit left, and we're going to remove that, and then we're done. You can actually see the nerve root right there. Okay, the nerve root is just below this. That's the nerve root right there. Okay, so we're done. We got rid of all the herniation, and I'm going to check the other side one more time, and then we're done with this 5-6 disc. Any questions?
Yes, we have a question coming from Faisal on Facebook
Sure.
saying,
Let
hi.
me guess. It's about his rib.
I believe so. Yes, it is.
All right.
Asking, I was told if I remove the 8th left rib with a benign lesion, I might get other nerve pain after surgery, such as numbness. Is that true? Though if they remove the rib with the lesion and will cut the nerve at the part of the rib that sits inside the rib, then the nerve pain will also go away if they cut the nerve.
It's a little dark. Yeah, Faisal, I don't know what other surgeons are going to do, okay? But in the end, you've got to decide what you want to do. I told you what I would recommend, so I can't tell you what other surgeons will do. I'm not able to read minds of other doctors and predict the future from other doctors' surgeries, okay? All I know is with other doctors, other surgeons, all bets are off. They could really hurt you. Move that, please. It's in my way. So, I don't trust other surgeons. Most surgeons, in my experience, are bad. They don't do a good job. They make mistakes. They hurt patients. They make bad choices for patients. They choose the wrong surgeries. And they make mistakes in the operating room, and they don't care. They just let the patient suffer with the complications of their mistakes. Very common. You cannot assume that all surgeons are equal, because we're not. If you want the best, you go to the best. All right. What do we got? Shot? Perfect. So we're going to come out. Luis, come on. I need you over here. These are in the way. I'm going to come out with this tube, and I'm going to leave the dilator. Shot? I'm going to go down to 6-7. Shot? Any other questions?
Yes, we have a few questions. This next one is coming from AAKK on YouTube.
Hello there. Shot?
Saying, hi, Dr. Duke.
Hi.
I noticed on the C5-C6 disc you lasered away what looks like a significant portion of the
Shot.
posterior annulus. With regard of healing, what is the best way to prevent re-herniation?
Yeah, so that posterior annulus is already torn and destroyed. It was massively torn. You could see it on the discogram. It was a huge tear. Shot? He also has a fracture here. You can see the bone where I'm working just below my dilator, which is number 6, is fractured. So he must have had some significant trauma. The fracture is healed. It's not causing any symptoms, but it was fractured. You can see how it's lost height, okay? At least on half of it. So now I got to make my way down. His annulus is like every other annulus. It's torn, and it's from inflammation, which destroyed it. It's been destroyed by the inflammation over all the years. So I debride it, but the body will heal it. Remember, the annulus is made out of collagen and elastin, mostly collagen. And when the body heals this, after I'm done, it's going to use collagen and elastin to heal it. So the annulus is one of the few tissues in your body that can be healed by the same tissue that your body uses to heal things, which is scar tissue. We call it scar tissue. All right, but scar tissue is basically collagen and elastin. Shot? All right, let's go with an AP, see where we are. I'm moving down from C5-6 down to C6-7. 6-7 is the next disc. Jordan, you've got to get a better shot. All right, that lateral view, looks like there's, scoliosis. You're not wagging properly for some reason, okay? So, shot. Any other questions?
Yes, another question coming from AAKK once more on YouTube asking, does the disc heal completely in this aspect with a large gap in the annulus? Also, I may be looking at it wrong. Please help me understand the disc's recovery in this situation if possible. Thank you.
Even with a large annular tear, once the Duke laser disc repair is done, the annulus will heal normally. All right, we got to get those end plates lined up. You got to figure out the WAG situation. Shot? Holy God, Jordan. That's better for sure. That's better for sure. That is definitely good right there. You can leave that. All right. He's got some scoliosis. You can see it on the x-ray. I need to move further south. Shot. That should be good. I'm a little bit off to the side. Shot. That's perfect. I need an AP. We're going to check the front. Quick shot. Perfect. You're right in the middle. Lateral. You can see the endotracheal tube and esophageal temperature probe are pushed to the side, which is what we expect. All right, so I slip back up a little bit. I'm going to come back down. Shot. All right, right there. Now I need another AP just to make sure I'm in the right spot before we get started. Quick shot. Lateral, perfect, lateral. So the AP looks amazing. We've lost 1 drop of blood, the whole surgery, 1 drop. All right, there it is. We're dead center. Shot. Shot. AP. I want to go back to an AP view, make sure I'm still in the middle. You have to use multiple views, AP and lateral. Any questions, Henry? Perfect. Any questions, Henry?
We have a comment coming from Lanu.
What is this? No, you got to watch the end of that. It's hitting my elbow. I'm moving my elbow in that area. That is the wrong place for it. I'll take Lanu's comment.
Saying C6 seems to be worse compared to others.
Yeah, it's C6-7.
C6-7, yes.
Yeah, C6-7 is worse. It's the worst of the herniations. That's what I'm fixing right now. My point earlier was that 5-6 was a lot worse than it looked like originally. Shot. All right, just about done, and we're going to get started. Shot. All right, good. You can see the tear. Show us the tear, Jordan. That's the tear. What you're not seeing is how big this herniation really is. It's huge. Shot. Shot. All right. Dilator is in position. Guys, we've lost literally 1 drop of blood. It's amazing. Bloodless surgery, the Duke laser disc repair. Every other surgery, patients lose lots and lots of blood. Plus, the other doctors are going to put metal plates in your neck or cages or plastic. You don't want any of that unnatural stuff in your body. It creates problems for your body. They even did a study recently and found that orthopedic artificial joints, like artificial discs, knees, hips, start to have what's called wear fragments, where pieces of metal come off and they get into your spinal fluid and they cause dementia. Patients are getting dementia. So it's better to do things naturally when you repair the body. This is a natural repair. We're not putting metal in. We're using these metal tools just to do the surgery, and then we take them out. And we don't leave any metal in. So there's no fusion, there's no metal plate, there's no metal cage, there's no plastic cage. This is all natural repair of the disc. Shot? Any other questions? Shot? All
At
right,
this
we
moment,
are
no
there.
current questions.
We are perfect position with the tube. Yep, I'm happy with that. 2, let's count. 2, 3, 4, 5, 6, 7. All right. 2, 3, 4, 5, 6, 7. Show us the height of number 3. Look at the height of vertebral body 3. See that? Now go down to 6 and 7. Or 5, sorry, number 5 and 6. Look at that. It's not really the same. It's kind of been fractured. I think this patient must have had some trauma a long time ago. The fractures are healed. They don't need to be treated, but the disc injury between the fractured vertebral body does. And that's where his symptoms are coming from. It's probably a 20% loss of height. It's not really that much. He should be able to have a normal life. All right, here's the herniation at 6-7. There's our laser fiber. It's 0.5 millimeter wide. Let's show the audience how disc injuries can cause neck pain and other symptoms, and how we fix it with our laser surgery.
Disc injuries start with an annular tear. Damaged nucleus pulposus herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals. For more details, please visit our website at www.dukespine.com or call us at 1-800-FIX-MY-NECK 349-6963. Disc injuries is a common cause of chronic neck pain. The inflamed annular tear causes neck pain. A 4 millimeter skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes herniated disc fragments and debrides the posterior annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website at www.dukespine.com or call us at 1-800-FIX-MY-NECK 349-6963.
Okay, welcome back. So you can see we're using the scope and a little tube and a laser. So the tube is called the tubular retractor. The scope is the endoscope, and the laser is a laser. It's a medical laser. We use a holmium YAG laser. This laser is made in Israel, and it's literally the best laser in the world that I'm aware of, and it's the best for this surgery. We've been using this laser for 20 years, the same exact laser, okay? This laser fiber, I told you, is 1/2 millimeter, 0.5 millimeter. All right, there's a piece of herniation I've been working on, trying to get it shrunk down with the laser, chopping it into pieces. It's still pretty stuck down with scar tissue, and it's still pretty big, so I'm gonna just grab it with the grabber. You guys can see it right here. You see this? Let's put the light here. You see what I just took out right there, folks?
Yes, we did.
Now notice, this is not big, it's small. Put the metric thing there. You can see the millimeters right there, okay? So each of these herniation pieces, there's 3 there, they're small. They're like a millimeter, but when you have 30 of them, or 40 or 50, like this disc, then it all adds up, like a bag of marbles. I don't even know if people know what marbles are anymore. Do they know? Kids don't play with marbles anymore, do they? We grew up with marbles. Okay, gumballs. So look at the size of this herniation. It's huge. All these are pieces of herniation. There's probably 60. This is the 6-7 disc. This is the worst herniation right here. So many pieces of herniation. All of this is herniation. And I'm going to use the laser to remove them, because the laser does 2 things. It breaks up the scar tissue that holds the herniations down to the back here. It breaks it up, it removes the scar tissue, and releases the fragments so they can come out. Okay, you can see that happening. And the laser creates a shock wave, like a pulse, a blast, that shakes up the fragment and makes it loose so it comes out. That's the advantages of this particular laser over any other laser. That's why we use it. All of our lasers are FDA approved. Everything we use in our surgery is FDA approved. So our surgeries are completely FDA compliant, like any other spine surgery. And our surgeries we've done now for 20 years with exactly the same result, every patient. with over 95% pain relief from the disc. On an average, it's 99.6%. Pain is gone. 99.6, that's 100%. That's over hundreds and hundreds of surgeries that we looked at. So this is a curative treatment. The pain never comes back in the disc unless you re-herniate or re-injure it, which only 1% of our patients will re-injure their disc. Okay, and they have to lift something heavy or do something they're not supposed to do that. 99% of our patients follow their restrictions after surgery and they have a great result. They're very happy. They never re-herniate. We don't hear from them very much, okay? Now you can develop other problems besides the herniated disc, right? We showed you the video. There are 30 different causes of neck pain. And the discs are the most common. They account for 90% of neck pain. This patient has 3 discs causing his pain. 3. All right, 3. And if we only fix one, he's still going to have pain. So he has to fix all the ones that are causing pain. The other cause of neck pain is the facet joints. Now, he doesn't have facet pain, but he may develop it in the future. If he does, he'll have to come back and get that treated. All right, but right now he doesn't have it. Look at this herniation. I tried to grab it, but I couldn't get it with the grabber. I have to cut it in pieces with the laser. Any questions?
Yes, we have a couple of questions. This next one's from AAKK, once more on YouTube, saying, in prior surgeries, you have mentioned, Dr. Duke, that you do not like SI joint fusions. Are these all fusions including 3-screw fixation like SI lock? I have heard differing successes from patients.
Yeah, sure. So SI fusion. Why do doctors do SI joint fusion? There's one and only one reason in the world for SI fusion. There is no other reason. It's pain coming from your SI joint. Pain from the SI joint. Specifically, what causes the pain is arthritis or inflammation, same thing, in the SI joint. So sacroiliac joint inflammation or arthritis, same thing, is the cause of pain in the SI joint. And that is the reason doctors do fusions of the SI joint. Duke Spine Institute has pioneered the first ever non-fusion cure for SI joint pain. Cure. And it's done with a small wand where we go in and destroy the pain nerves. There is absolutely no reason to get a fusion done when you can have the Duke plasma rhizotomy, which works better than fusion. Fusions of the SI joint eliminate pain about maybe 10% of patients. And the ones you're hearing about are those 10%. And they're promoted by the companies that sell those screws that go across the SI joint. But there are many studies done now that show that SI joint fusion does not work. It does not work. And the most recent came out of, I want to say it was, Norway. I think it came out of Norway about 8 months ago, and it showed that SI joint fusion patients still have pain afterwards, and they're no better than those people that were treated with medicine. So in Norway, they don't even do SI fusions anymore. The only reason they're being done in America is because the companies that make those screws make so much money and profit, they basically bribe the politicians and, I don't know, probably the insurance company somehow to allow their procedure to be done. It's unnecessary. I do not recommend SI joint fusion ever. Okay? Ever. Like I said, there's no other reason to do SI joint fusion other than pain coming from the SI joint, which is always due to arthritis. There's no other cause. Okay? You don't do SI joint fusion for fracture. You only do it for pain. You don't do it for tumor. You only do it for pain. And that pain is always from arthritis of the joint. There is no reason to have those metal screws put in your SI joint when you can have the Duke plasma rhizotomy. Henry, let's show the audience the Duke plasma rhizotomy for SI joint.
Of course.
Sacroiliac joint injury is a common cause of chronic back pain. The inflamed sacroiliac capsule tear generates pain signals. The best treatment for sacroiliac joint pain is the Duke plasma rhizotomy. Sacroiliac joint pain nerves are destroyed. The advantages with the Duke plasma rhizotomy is that it's an outpatient procedure that takes 30 minutes to complete, very minimal bleeding and pain after the surgery with immediate recovery and return to work the next day, as well as a 99% success rate and permanent pain relief with a single treatment. For more details, please visit our website at www.dukespine.com or call us at 1-800-FIX-MY-BACK, 349-6922.
Okay, welcome back. Our patient we're working on right now has herniated discs in their neck, and he has traveled here from Iraq. We're just about done with number 6-7. There's a lot of scar tissue. You guys see all this stuff here is scar tissue. I have to get through it and see if there's any herniation on the other side of it, which I'm worried that there is, okay? So, thank you. But to answer the question about the SI joint, there's no reason to have an SI joint fusion anymore. I would strongly recommend against it. Even the 3-screw version. There's such a painful and bloody and high-risk surgery. There's zero reason for you to do it. All right, so here we are in the foramen on the left at 6-7. There's a massive amount of scar tissue here. And I think there's some herniation here, scarred down. I'm using the laser. I'm removing literally 1/20th of a millimeter of tissue. Remember, that laser fiber you're looking at is 0.5 millimeter, 0.5. So I'm removing right now about 1/10 to 1/20th of a millimeter of tissue. That's how precise laser surgery is with the endoscope. So there is no surgery in the world as precise as what I'm doing right now. There's a massive amount of scar tissue here. This poor doctor has so much scar tissue, and all these pieces of herniation, they just keep coming. This was the worst one, but we're getting it done for him. We have one more disc to go. Number 4-5 is the last one. I always try to do the hardest ones first. All right, keep the questions coming. I hope I answered your SI joint question.
Believe so. We have a few more questions. Next one is from CODFUE on YouTube, asking how much does this surgery cost? Is it only done in the U.S.?
Yes, the surgery is only done in the U.S., and the cost of our surgeries depends on how much work we're doing. How many discs are we fixing? 1, 2, 3. Also, is that surgery on the neck, or is it in the lower back, or is it thoracic? So the cost depends on several factors. One is what part of your spine, which disc are we fixing? Is it lumbar, is it cervical, is it thoracic? Because lumbar is the easiest and it's also the cheapest. Cervical is the second hardest and it's more expensive. And thoracic is the hardest and it's the most expensive. So I don't know the costs, but I do know that those facts. All right? But if you want to know, all you have to do is an MRI review to get a diagnosis from me. I'll tell you what's wrong and I'll tell you how we fix it. This is the back of 6-7. You can see the fibers right there, the PLL. I don't see any more herniation. We've removed a lot, but I'm going to keep looking just for another few minutes. I want to make sure we've gotten as much as we can. You guys can see on the MRI that we put there, this is a big, big herniation here, okay? So It looks like there may be some still here that went through the PLL. The PLL is posterior longitudinal ligament. Okay? So I'm going to have to go through the PLL and see if there's any more behind this.
We have another question
Sure.
coming from AAKK, once more on YouTube,
Yep.
asking, when lasering along the posterior annulus in the cervical spine, how do you ensure you don't laser too deep to compromise the anterior cord? And also in the lateral foramen, how do you stay safe?
Yeah, great question. So obviously we're doing that right now, exactly what you're asking about. And those fibers right there are fibers of the posterior ligament. So you can see there's a herniation behind it. You see that? Okay? Right there is a herniation. And so I'm basically lasering at 1/20th of a millimeter at a time. 1/20th of a millimeter. Right off the front of the spinal cord. So how do you make sure? Well, number one, you have good equipment, which we have the very best. Number two, you have good training. You have a surgeon who's really, really good at doing this surgery, which I'm the only one in the world that does this. So if you have somebody else other than me, you're in trouble, most likely, unless they've been doing this for 20 years like I have. But basically it comes down to your surgeon's knowledge and experience and familiarity with this procedure, familiarity with the anatomy. So there's a lot of factors that are important. There's a lot of important factors. All right, I'm going to just go take a quick look at that MRI one more time. Jordan, I want to look at 6-7. Any other questions?
At this moment, no current questions.
Do you have to change irrigation or are we good? All right.
We just got a question once more from Lanu asking, is the patient returning to Iraq after surgery?
Other way. Go back. Stop. So that would be left side. The question is the patient returning to Iraq after surgery? The answer is yes. I don't know what day he goes home. I'm not done yet. I want to go a little bit more. Can you guys see some of the herniations we've taken out right there?
Yes, we do.
There's a lot more that are washed down the side into the bags, but we have a decent collection here for you guys to see what they look like. Again, everybody thinks the herniation is one piece, but it's not. It's actually many pieces. And in this case, at this particular disc 6-7, in this patient, there's probably at least 30, maybe 35 pieces of herniation. All right, let me go the other direction. We're almost done with this disc, and then I'll be moving on to the final disc. I feel like we've gotten everything we can and need to on this disc. But I want to make one more look just to be 100%. That's the back of the herniation. You can see the fibers of the PLL there. And this is where the herniation was. There's a little bit of scar tissue left. I want to clean it. I want to make sure I got as much herniation as I can. But the way you avoid injuring things you're not supposed to injure is, number one, you got to have a knowledge and awareness of where they are, okay? And I do. This is scar tissue right here, all scar tissue from the body trying to heal this herniation, but unsuccessful, not being able to, okay? And this is, the body will now be able to heal it because I took the herniation away. It's gone. Now what's left is just scar tissue, and I don't see any more herniation. So I think this is a very good debridement with the removal of the herniation. I'm going to just check right here. There's a little bit left. I'm going to go to the foramen one more time. So much scar tissue on this left side. removing a bone spur right there. But we're just about done. I don't see anything really left here. Just scar tissue, very thin layer of scar tissue, which we cannot remove all the scar tissue. It's not possible. The rest looks good. It looks very good. I'm done with this disc. Any other questions?
Yes, we have a question from AAKK once more on YouTube asking, in what percentage of patients do you see herniations getting encapsulated behind the PLL?
Yeah.
Do you ever simply probe with the laser to release herniation?
Yeah, that's a great question. That's a really, really insightful question. What AAKK is asking is, Dr. Duke, how often is the herniation anterior or above the posterior longitudinal ligament, I think he said. And he didn't say
Correct.
ALL, he said PLL, I think.
PLL, correct.
Yeah. And then how often is it behind the PLL? The answer is 90% of herniations, maybe even 95%, do not penetrate through the PLL. 95% do not penetrate through the PLL. Just so you all understand, in the center of the disc is the nucleus, then there's a wall called the annulus, which is very strong. The only way the nucleus gets past the annulus is trauma, where you get an annular tear. And then the nucleus will squeeze out as little pieces of fragments through the annular tear. But does it ever tear the PLL? The answer is no. Very rare. Very, very, very rare. But it does happen about 5% of the time. All right, we're done with this disc shot. I'm going to move out of here, and we're going to get up to the last disc shot. So I leave the dilator, and then I do this, what we call the slide, where I slide up shot. All right, I'm going to slide up the spine. It's called the Duke spine slide, okay, because we invented it here at Duke Spine. We're the first in the world to do it. Remember, when I learned the endoscopic anterior cervical transdiscal technique from the Korean neurosurgeons, Dr. Seng-Ho Lee, Dr. Gun Choi, this was 20 years ago, I learned from them directly, and they did one disc at a time. They only did a single disc. And the reason they only did a single disc is that's safest and easiest to do. But many patients have more than one disc as the problem. This patient has 3. So what do you do for somebody, AP, that has 3 discs that are herniated? The answer is you can do 3 separate surgeries, do 1 disc each surgery, or you can try to do all 3 in 1 surgery. Now I think every time a patient has surgery, they go under the risk of anesthesia, having complications from surgery. So it's always best for the patient to try to fix everything in 1 surgery. And that's what we do at Duke Spine. So to do that, I had to find a way, AP, to treat more than 1 disc, because all the other doctors, which was really only one other doctor doing the surgery, the Koreans, they only did 1 disc at a time. So they couldn't teach me how to move from 1 disc to another. I had to figure it out on my own. So that's why I do what I do. Hold on. Shot. Whoops, slid. It's very slippery, by the way, here in the front of the spine. Shot, because you have a ligament called the ALL. Shot. Lateral. So this is called the anterior longitudinal ligament. It runs in front of your spine, in front of the disc, and holds everything together. And of course, when they do fusion surgery, they cut that ligament. We don't cut the ligament. All right, so 2, 3, 4, 5. I'm going up a few more millimeters. Shot. Here we are. I need to make sure I'm in the middle. I like the lateral view, but I don't know what the middle view looks like. Shot. It's very slippery. So that view looks good. I'm happy with that. Let's go back to a lateral. You guys see the incision? It's a 4 millimeter incision. I'm fixing 3 disc herniations with 1 4 millimeter incision. In this doctor, give me an AP again. I just want to check AP one more time. This is a doctor from Iraq. He traveled here for the Duke laser disc repair. We have, yep, see, I slipped. That's why we have to always double check. Okay? Never ever assume. Assumption is the mother of all,
I think again, also, good.
Assumption is the mother of all. I didn't say this, but I'm just quoting. It slipped again. It's very slippery. Very, very slippery. Shot? So you got to be very, slipping again. And part of it is his muscles are starting to come back. His muscle tone, lateral. No. I'm just about done here. The muscle tone is coming back, the skeletal muscle tone. Therefore, the patient, shot? Let's get another AP. Therefore, the patient's muscle tone's coming back. It's starting to fight me, but not enough that I need to give him another dose. I don't want to make him so relaxed. Shot? All right, I'm happy. I'm just going to have to radiate my hand. Shot? That's perfect right there. Now give me a lateral view. That looks perfect. Shot, AP. I'm going to check again. You always have to check, because if you don't check, you can be to the side of the spine and it will do very bad things to the patient. That looks perfect. I won't even talk about those bad things. I've never had that happen. I don't expect it ever will, but there's lots of things to the side of the spine that you don't want to be messing with as a surgeon, okay? Very bad complications. I've never had one, but that's because I'm very cautious. Shot, any questions?
At this moment, no current questions.
Shot? All right. Hold on. This will be our last disc. It's a smaller one, but should still be interesting. I can still get it in that little hole. Look at that tear. Shot? Look at that tear, folks. Look at the tear. That is the tear. This dye should not leak back there. That tear tells you there's an annular tear, and it's big. Not as big as the first one we did, number 5-6, but it's still big enough. And I've got to angle my dilator down towards the tear. There we go. You see that? And now I'm inside the tear, and that's where we want to be. We are doing an annular debridement. Everything's being done, in case you missed it, through a 4mm tube. The whole surgery is 4mm tube. Our patients have never had a complication from this surgery in 20 years. It's the safest shot surgery that can be done. But it has to be done by an expert like me on endoscopic anterior cervical transdiscal surgery. This is the future of spine surgery for the entire world. You're watching it. Whatever else is out there is worse than this. This is the best. We only do the best surgery in the world on our patients. We don't do less than the best. So everything else out there, fusion, ACDF, artificial disc, total disc replacement, all these surgeries done in Germany and around the world, they are being done. They are worse treatments. 2, 3, 4, 5. This is the very best. The problem is those surgeons don't know how to do the surgery. That's why they don't recommend it. They don't know how. This is a very advanced surgery, the most advanced in the world. Look at that precision. Now, we also have the very best equipment at Duke Spine Institute in the world. There's nothing better. We have the best fluoroscopes, the best endoscopes, the best laser, the best everything, the best people to help me do these surgeries. And we have the best technique. Technique is very important. You want the best technique if you want the best results. You have to have a surgeon who is uncompromising, unwilling to do anything that isn't perfect. Because any deviation, even a millimeter, can really hurt the patient badly and make the results very bad. That's why you need someone who is principled and will not compromise. Shot? All right, so I'm almost done. What happens is the dilator keeps getting pushed back. What's pushing the dilator out of the tear is the pressure inside the disc. It's called hydrostatic pressure. And the reason there's so much pressure in this disc and in the tear is inflammation. It's happening. Inflammation creates swelling. You've all seen the inflammation, right? When you have a pimple on your face, it's swollen. That pimple is swollen. That, right? All that edema, all that congestion, vascular congestion, has caused a swelling, and that swelling puts pressure because it's mass that's in an area that's not supposed to have a mass. That mass being the swelling, the edema, the interstitial fluids. You doing all right? Yeah. 10 minutes. So why do I know so much? Because in medical school, I studied every day, all day, from 7 a.m. until midnight, every single day, 7 days a week for 2 years, especially paying attention in pathology, histology, and anatomy. Those are the most important classes to understand human disease. And of course, microbiology. The point I'm trying to make is, I was number 1 in my class at USC in Los Angeles, the University of Southern California. This is one of the hardest schools. The school was 120 years old. We had students from the best colleges that were in my class, and I ranked number 1. I ranked 1 because I studied all the time and I had the ability to learn material. But pathology is the most important class in medical school to understand human disease. Pathology is the study of human disease. So I studied pathology and I studied it well. I scored 100% on my final exam at the end of the year at USC. That is an exam given by the professors who wrote the actual book in pathology for all medical schools, Dr. Clive Taylor and Dr. Pakrama Chandrasoma. They created a test that was the hardest test they could ever create, and I scored 100%. What does that tell you? It tells you I know pathology very well, which is why I understand all these diseases, which is why I can actually come up with solutions for patients to cure their pain. It's because of that hard work I did in med school in gross anatomy, histology, and pathology. What I'm saying is, for future generations, if you want to lead in medicine, you want to be a leader, you want to discover cures, you must study hard in medical school. And before med school, in undergraduate, I was a biochemistry major. I did very well in biochemistry. So studying biochemistry, having a foundation for medical school in the hard sciences like chemistry, biochemistry, you start to understand at the deepest level how human life works. And then you go from biochemistry to cellular biology. You can also study genetics, molecular biology, which is how genes are expressed, turned on, turned off, how they encode proteins and enzymes that then regulate all the things that happen in your body, okay? This disease right here, this herniated disc, this pain, this inflammation, it's all because of cellular processes, okay, and biochemical processes. So what are the cellular processes? Well, you have cells called leukocytes, specifically polymorphonucleosides that come in with inflammatory cells, and they release enzymes that try to break up the herniation, but it doesn't work. It causes all this damage around called collateral damage, which then the body tries to heal after that with scar tissue. So that's why these herniations have so much scar tissue. They have inflammation, they have scar tissue. We're seeing that right now. This is scar tissue right here, all this white stuff, okay? So I'm cleaning out his scar tissue that he has back in the back of the disc. That's going to allow the back of the disc to heal properly. 5 minutes. Any questions?
Yes, we have another question from AAKK, once more on YouTube, asking what is the it's saying, thank you, Dr. Duke, for the amazing work you do for patients. What is the highest level you have performed the DLDR in the cervical spine? Is it possible to do C1-2, C2-3? Just curious.
Yeah, great question. So there is no disc at C1-2. There is only a disc at C2-3. I have done 2 patients at C2-3. They had herniations at C2-3. Both of those patients were injured in an auto accident, so they had an unusual reason to have a herniation at C2-3. C2-3, you almost never, ever, ever see a herniation. But I had 2 patients. There's a herniation right there. You see that? It just came out from the annular tear. I mean, from the behind the PLL. Okay, that's through the annular tear. It just came back. We call it a reherniation. Sorry, a reverse herniation. Not reherniation, reverse herniation. Okay, so C2-3, I've done 2 patients in 20 years and over 2,700 surgeries. It's not common, but it is doable. I've done it. You have to have the right kind of neck to do it, and you have to have the right kind of neck to injure it. So you have to have a long neck, and this patient has a long neck. He could have a C2-3, but he doesn't, thank God. He only has 3 disc herniations. Right there, you guys see that? That is herniation that went kind of through the PLL. There it is. So even number 4-5 herniation, the easiest of them, the least of them, the smallest herniation is a bad one. And it's a good thing he got this done, because if he didn't get it done, he's going to come back and get it done. Okay, we were talking about this when I scheduled his surgery. I did his telemed, his Zoom call. By the way, we offer free virtual consultation to anybody in the world that wants to know why they have neck pain or back pain. It's free. You just go to the Duke Spine website and you fill out our MRI review form. The only requirement, you have an MRI scan and you give it to us so I can see it. I must see your MRI, not the report, the actual scan itself. So this patient, he's a doctor from Iraq, and he and I were talking, and I showed him on his MRI, based on his symptoms, I said number 6-7, C6-7 is the worst one. If you fix only one, that's the one you have to fix. But I said I highly recommend you consider fixing number 4-5 and 5-6 because they're also very bad. Okay, they're also very bad. And he decided he would listen to me, and he did it. And thank God he did, because number 5-6 and 4-5 are very bad. They're not just bad, they're very bad. But you don't know that from his MRI. If you look at his MRI, it doesn't look so bad. But now that I'm here, I'm inside, I can see it with the endoscope. I can see how many, look at all these pieces of herniation at number 4-5. This was the easiest one, the one that had the least herniation. But it's got at least 30 pieces of herniation, and they went through the PLL. Right there you can see through the PLL. So this patient, because he has the fractures of the bone, he must have had a serious trauma to his neck. I don't know what happened. Anybody know how he injured his neck?
Yes, he recalls no trauma.
He recalls no trauma. He said no accidents, no trauma in his life. So here's the thing. When I see patients like this that say no trauma to my neck my whole life, I believe these people had an injury when they were being born, coming out of the birth canal. I believe that the OBGYN grabbed the neck and flexed it. Have you ever watched an OB-GYN deliver a baby? They literally grab the head and they push it down. They push the chin down to the chest. They hyperflex the neck. Try to get the head coming out of the vagina or uterus or whatever it is. Not my area of expertise. But when you do that hyperflexion of a baby who's a newborn, they don't have the protection of the spine, the strong ligaments and tendons. They have weak ligaments, weak tendons, weak discs, because they're newborn. They're soft and they're compliant. So I think that those injuries are happening when people are being born, and then they have no history of trauma their whole life, but they end up with these horrible herniations. I believe in this case that's probably what happened with this patient. All right, we've got about 2 minutes left. I'm just getting the last of this herniation out, and then we're going to be done. Any questions?
At this moment, no current questions.
All right, so just to tell you, he had 3 herniations. He did not want fusion. He did not want artificial discs. He came all the way from Iraq. Everybody knows where Iraq is. He's a doctor in Iraq, I can tell you that much. And he did his research. And he realized what I'm doing at Duke Spine is the most advanced spine surgery in the world. So he came to America for his surgery. And he's not the only Arab that's coming. Okay, we have other Arabs that are coming now because they're finding out about Duke Spine and what we're doing, and they're coming. And we actually have Arab-speaking staff that speak Arabic here. So we can help these people when they get here and make sure that they're cared for, accommodated. All right, just about done. Any other questions?
No current questions. We do have a comment from AAKK saying nice PLL herniation removal.
Thank you. Yeah. Not what I expected based on the MRI, but you know what? That's all right. You can see the last fiber of the PLL right there, AAKK. You see that little strand right there? And then right behind it is the dura of the spinal cord. So this is all scar tissue here, and this is a little bit of herniation, the last piece, hopefully, right there, coming out. Boom. Just about done. This patient's going to go home in an hour, by the way. He's going to go back to his hotel. His lovely wife is here to care for him. And then he's going to fly back to Iraq, I think, tomorrow. He came to Florida not for Mickey Mouse. He came for Duke Spine Institute. Right? Because if they want Mickey Mouse, they just go to Dubai. All right, any other questions?
At this moment, no current questions.
Okay, well, in that case, this is the last of the herniation and we're done. That's the foramen at 4-5.
This is a very sensitive disc.
Really? Yeah.
Very sensitive.
This is probably a newer herniation.
Rates up 25.
Oh, good.
Right in the anesthetic.
Oh, we're done. I'm done. We're done. It's beautiful. Thanks for joining us. We'll be back in a little while with a patient who comes from California, Los Angeles. She has a L5S1 herniated disc that needs laser surgery. She has a piriformis muscle tear that's severe and causing a lot of pain for her. And so we're going to go in and fix those for her next. Thanks for joining us. We were able to do the entire surgery through a small 4mm incision. And this patient's going to basically go home in an hour and a half. I'm here with my patient who traveled from California, Northern California. He had a herniated disc at C5-C6. It was a small disc bulge. He was told by the doctors in California that he should just live with the pain, give it time, and eventually he'll need a fusion. Is that right?
That is correct. I was told that within 5 years I would be needing surgery. So basically what they were saying, live with pain for 5 more years and then we'll do something about it. One of the things that I've seen a lot of the videos is testimonials, and I will always say, this doctor sounds too good to be true. And actually it is true. I appreciate you, doctor. I really think that is really nice procedure, and the staff here is really nice. They're always very friendly and kind to get you through the process, because when you get told so many times that that's your new life, it's kind of, you're always thinking, is really the way I want to live? If I'm going to live a lot of years, why wait with pain? You know, you need to do something different. And always, whenever you see videos, you're always a little sketchy and saying, maybe it's not true. Maybe this is not what it is really saying. But today, when I felt with no numbness and no pain on the neck and just going through the process, I really been blessed. I'll be flying to California today. I honestly can't say much. You know, it's a miracle. Whenever I heard the testimonials, they say you're a tool for God. It actually seems like that's the way it is. It's a miracle through you. God works through you, and it's awesome to feel better, you know?
I'm so happy for you and your lovely wife who's here with you. You can see you had a tiny little incision. You had the Duke laser disc repair for your herniated disc. You can see we were in there with the laser, cleaning out that foramen on the right side where the nerve was being pinched. There were a lot of pieces of herniation in there. And the laser cleaned them all out, and your surgery went perfect, and here you are less than 24 hours later. Feeling good, huh?
Well,
With
yeah.
a smile on your face. That's what I like to see.
You know, it's a smile of happiness. It's a smile of joy, you know, that it is doable. And I think no one should be able to be living with pain. I was so happy to see testimonials when they used to say, well, the one regret I have is not going in earlier and living 18, 20 years with pain. For me, it's been 3 years since July of 2020. It's been miserable because I've been with pain. And I've been told by doctors, let's just take time. I did all kinds of physical therapy, acupuncture, you name it, everything that's out there, and nothing seemed to help. And today, with one day of getting something really that's gonna be for life, it's amazing. It's a smile of joy, you know? If you are going through this trouble, don't hesitate on sending your MRI. When I did it, I sent my MRI for free review, and my answer was, yes, you are a candidate. Here I am today, flying back with literally no pain on my neck and no numbness on my hand, which I miss that. It's awesome.
It's wonderful. Now, what is your native tongue? What is your native language?
It's Spanish.
Are you from Mexico originally?
Guadalajara, Jalisco, Mexico.
Guadalajara.
Yes.
One of my favorite songs. Can you tell them in your native tongue how you feel?
Yeah. Quisiera decirles que si están teniendo problemas con una hernia en su cuerpo, manden su MRI, es gratis y les van a dar un resultado, una verificación si ustedes son candidatos. No vivan con dolor, porque el dolor les va a causar toda la vida y los doctores allá afuera les dicen que no hay solución, pero las soluciones existen, simplemente las tienes que buscar y creer, tener fe que tú vas a estar mejor. Si Dios te mandó a este mundo es para que vivas bien, no para que vivas con dolor. Así que te recomiendo que por favor tomes esto en serio, hagas ese paso de mandar tu MRI gratis y habla ya sea con quien tengas que hablar para que ellos te empiecen a guiar y te digan qué es el siguiente paso que tienes que tomar. Así que una recomendación con Dr. Duke. Muchas gracias.
Muchas gracias, amigo. And Feliz Navidad.
Feliz Navidad. Gracias.
Safe travels, my friend. Thank you so much for sharing.